So extensor tendons. I feel like I can never talk about this stupid topic enough. I swear this is harder than flexor tendons. I don't know who came around and was like, oh, we need to like research tons of flexor tendons. Extensor tendons are where it's at, right? So extensor tendons. So I hope that you guys have some paper. I hope you guys have some pens for your hands. It's really, really key. I'm gonna go over a couple of things. So first, you always want to think about the mechanism of the method of injury, right? So this is where you can sort of get tripped up in terms of method of injury with an extensor tendon, you know, as compared to flexor tendons and stuff like that. With an extensor tendon type of injury, there's several methods. So it's not just laceration, right? Laceration. Right? But it can be ruptures. There can be ruptures. And if you think about the ruptures, where can the ruptures take place? It could be due to scaphoid types of fractures or injuries, or really it's like a non-healing one. It's like a non-healing, non-union type of thing. If you can imagine anything on the back of the hand that becomes jagged, where it becomes jagged, like bone becomes jagged and stuff like that, and it slowly starts to saw away at these tendons, that's essentially what ruptures can be like. And it can be due to rheumatoid arthritis types of issue. It could be due to ulna, distal radius types of issues, right? Like if you have a fracture and it's malaligned, if you have surgery like plates and screws that are sticking out and over time start to rub and cut people, right? Other ones are like Kenbach's disease, and this one, it's Madelung's disease. I forgot even what that was, but Kenbach's disease is a lunate issue, right? Kenbach's disease is a lunate disease. But anything that is, if you can imagine back here, that can become somewhat of a jagged saw, cut some tendon, and therefore you have ruptures. And of course, complex types of injuries, such as fractures, right? So fractures kind of goes back to like distal ulna, plates and screws, but it can happen anywhere in the hand where you can have tendon types of issues, where it's not just about the laceration, the rupture, but complex injuries, meaning that they're stuck somewhere because of scarring, right? So on the exam and really in real life, when you work, you're just going to see these types of injuries. And so if you see them in your clinic in terms of, oh, like how are they coming in, and could their tendons be stuck due to scarring and stuff like that, due to a complex fracture. I have a guy whose fracture was circumferential. He had a crush injury, and they tend to be crush injuries. And of course, it cut along the side of his finger all the way around like this. He had a fracture P1, and it really messed up his PIP. But how is it messed up? It's really not a bone issue, right? His bone is stuck, his joint is stuck, but so much of it is due to an imbalance in his tissues. And if you go around like this, you cut here, so what kind of tendon are you gonna have? What kind of tendon issues are you gonna have? And then it's he had like it, because it crushed him all the way down, it literally just like busted his skin. So he has a circumferential scar that goes around like this. So once we start going over anatomy, we're going to see, well, what's anatomy over here? What's anatomy on the side? And if he can't extend his PIP, or potentially some of the problems he's going to have, so your method of injury and your laceration, ruptures, or complex injuries are going to be the stories that are being played out to you on the exam, just like they're played out to you in the clinic. Right? So just make sure that when you're thinking through, just slow yourself down a little bit and think about the method of injury, right? And then you're always going to be reminded about healing. right? Healing requirements. Well, if it's a tendon, how do tendons actually heal, right? So tendons heal through bridging of the collagen, which is basically scarring. So it really comes back down to, you know, they have to suture it up. And when they talk about suturing, make it really simple for yourself. You know, with extensor tendons is a little bit more complex, right? Because they talk about the shapes of the tendons. Like some of the tendons down here are more round, and then some of them are more flat. They talk about how they have to suture them in, but it's all suturing basically, because tendons heal, extensor tendons heal the same way as flexor tendons heal, meaning that it requires scarring, so you have to sew it together. It requires a certain amount of scarring that builds up to make it strong, right? The best thing about extensor tendons is that it's easy because it doesn't need to be surrounded by that sheath that gives it glide, right? Because it's got the dorsal fascia right here, so it's not necessarily in any kind of synovial type of fluid, except for the thumb. All right, I'll get there later. But the hard part is that it's not in anything and it's got the dorsal fascia. And usually what happens is there's just no room for error. There's no room for injury basically in the back of your hand. Always when you're going through that type of thought process and thinking through a problem, look at your own hand, look how it's supposed to normally move, and then think what happens when things get stuck down and they don't move. So that's a difficulty in the healing requirement. So it doesn't require synovial, so it actually heals pretty nicely. The problem it has is that it gets scarred down. Now, just like a flexor tendon, extensor tendons can also gap, right? So they have to be sewn in a certain way, they have to be positioned in a certain way so that there isn't that gap. So if you move it too early, it's going to pull apart because it didn't have that time to really like solidify. But if you move it too late, then it gets really stiff and everything gets scarred down. So hence the most difficult type of problem. And the hardest zones tend to be from 1 to 4, right? The smaller the joint, the smaller the structures, the harder it is. Right? So the healing requirements are pretty much the same. Just keep those things in mind when you're thinking about what's going on, right? And then the third thing is anatomy. We always come back to anatomy because it really helps us to problem solve through what we need to be doing as a certified hand therapist and anticipating potential problems and being able to get through them without as many complications as possible, right? So we're gonna go more in depth into anatomy. And then what happens is because you know your anatomy, you're gonna know about surgical types of interventions and therapy types of interventions. So if you kind of think about that way you can break it down. So if you know how it got injured and you know how tendons heal and you know the anatomy, then surgically you'll know what needs to be done, and then therapy. So the surgery and the therapy is actually pretty much about applied knowledge, right? So you're gonna take what you know and you're gonna work through these particular problems, right? Flexor tendons, they are at their weakest in day 10. Is there something like that with extensor tendons? Yes, pretty much. They follow the same type of healing, that they're weak, and then of course there's the drag, and then there's the potential lag and stuff like that. I think more so in extensor tendons because you don't have a lot of tissue, right? You don't have a lot of tissue, so there's always that drag. And then if you think about how edematous the back of your hand is, so when we make a fist, it's the pull and push of our skin that pumps the fluid out of the back of the hand. So what happens is fluid tends to stick and stay in the back of the hand. So we just have to keep those things into consideration when we're working with any kind of tendon issue. But tendons, essentially, the healing requirements are the same. They can't rupture and everything like that. These just tend not to rupture as much, I think just due to the fact that it tends to scar down before it even has a chance to rupture, right? So it just scars so fast because there's no tissue. at 2 weeks, you're already scarred down more than you are scarred down on a flexor, right? So even if it were to rupture, it wouldn't rupture, it would lag, which is the biggest problem. You might not be as attentive to a lag of flexor tendon, but you definitely can't progress if you lag in an extensor tendon. Like at a flexor tendon, you're like, okay, 6 weeks, I'm allowed to passively push, you know, or I'm allowed, the protocol is just like in a way the opposite, right? But because you are allowed to do passive first, right, in a passive, and then you're allowed to start to do active, right, in a flexor tendon. And even if you have a lag, you keep going. You're like, keep pushing that passive. I need passive range of motion. In an extensor tendon, you wouldn't, because of how stretched out it can become, just because it's on the back of the hand. So for what you need to require for flexion, it stretches it more. You'd have to, you know, put it like this, but even with the wrists extended, you can only do one or the other because of its anatomy and position on the back of the hand. I hope that makes sense.